Today we are going to talk about the Diagnostic and Statistical Manual of Mental Disorders, abbreviated as the DSM. We'll talk about some of the advantages and disadvantages of this model. First of all, it was first constructed in 1952. At that time, it was mostly based on Freud's ideas of personality disorders. And there were very few categories, in fact. However, the DSM evolved over time to fit with more modern theories of psychopathology. By 1994, the fourth version of the DSM-4, listed more than 250 psychiatric disorders. And now, the most recent version is called the DSM-4-TR, which stands for Text Revision. It was published in the year 2000, and again by the American Psychiatric Association. And fortunately for students who are listening, there will not be another revision until it's anticipated 2013. This manual, as I said, was published by the American Psychiatric Association, which is abbreviated as the APA. It covers all mental health disorders for both children and adults. One of the great advantages of this particular model, or diagnostic model, is that it is non-theoretical. This means that we don't have to worry about what the causes of the disorders are. Instead, in a very behavioral approach that is highly North American, we look at people's observable symptoms and we diagnose on the basis of those symptoms. So the symptoms are described in this manual to be helpful to the people that are using it, the professionals. There are statistics or proportions concerning which gender is most affected by the illness. So for example, you might find out that a particular personality disorder, like antisocial personality disorder, affects males more than it affects females. Whereas another one called borderline personality disorder is probably most diagnosed with females. We also find out about the typical age of onset. For example, you might find out that people suddenly change at the age of 22 and they have a type of schizophrenia where they are experiencing psychoses. And it's very helpful to know that what is happening is typical at that age, so the diagnostician can sort out what is going on. In addition, the manual provides information about likely prognosis. And to recall, prognosis means how well people will do in the future, whether or not treatment is going to be effective, or whether or not they'll be completely cured or have to live with their particular symptoms with the best possible treatment. The manual also tells us about the effects of treatment. Also, what's very helpful for practitioners is to know what the optimal treatment approach might be. So I might discover as a practitioner, for example, that it would be better to give somebody with major depressive disorder a type of psychotherapy, whereas somebody who has a more serious type of depression, such as bipolar disorder 2, might require some kind of psychiatric medication, because psychotherapy alone will not be helpful if they are, for example, experiencing psychotic symptoms where they might, say, hallucinate. Let's look a little more closely now at the 5 dimensions that make up this multi-axial approach. In other words, there are 5 axes or 5 dimensions where we will observe what is going on with a particular individual. The first axis is often seen to be the most important to diagnosticians, because on this axis, all the major clinical syndromes are indicated. So for example, if somebody has an anxiety disorder, this would fall into the category of clinical syndrome, as would depression. There are 2 other categories that fall in axis 2. One is personality disorders, and the other is mental retardation. And you might ask, well, why would these two be different from clinical syndromes? Isn't a personality disorder a clinical syndrome? And in fact, what personality and mental retardation have in common is that they are very long-standing patterns, or what clinicians call pervasive patterns. This means that they are not as likely to change with treatment. What do personality and patterns and mental retardation have in common? Well, mental retardation is also a long-standing problem. Basically, it is characterized by intellectual impairment or some kind of deficit in other areas, such as self-care and interpersonal skills. So let's take a person who might have a lower IQ because they have Down syndrome. We would treat this person in a different way than we would treat somebody with a clinical syndrome. Axis 3 allows us to notate or take account of whatever medical conditions the person might have in addition to the psychological problems they might have or symptoms they might be experiencing. On Axis 4, we look at psychosocial and environmental problems. It's very important to know what is going on in the context somebody lives in. In other words, if they're experiencing something like marital problems or a conflict with a child, this could really affect the clinical syndrome on Axis 1. So somebody who's depressed, who also is experiencing a loss of a job, a spouse who has left, and children who are having difficulties would of course need extra help or a different kind of psychosocial support in addition to treating them for the clinical syndrome. So it's really helpful to know that. On Axis 5, we look at somebody's global assessment of functioning. And in fact, this is a flexible measure in some ways. We can rate the person on the highest level they functioned within the previous year, or we can look at whatever time period it has in front of us. So if somebody comes in to a diagnostician and they only can talk about what has happened in the last 4 weeks, or that's all you know, then you would put your rating in terms of the present on that Axis 5. Modern diagnosticians have found that this system helps them identify and describe clear and distinct disorders. In other words, as a diagnostician, I can look at people's depressive symptoms, and after giving them, asking questions based on the DSM criteria, I can determine what different types of depression they might have. It also helps me have the same language as my peers, so we can share information about our patients and know more about what is already known about the disorder when we go to treat them. So if you like, you might say that there's a provision of a special language for behavioral disorders or psychological problems. It also allows an exchange of information about research findings and clinical experience. It also allows me to identify potential causes of a disorder, the predictions of the future course of the illness, and I can make decisions on an appropriate treatment because I'll have information presented to me in this manual based on previous evidence-based research. Is this a perfect system? No. It would be difficult to find a perfect system across cultures that could identify all types of psychological or psychiatric problems. But it's a helpful system. Let's look at some of the things that people have said who have criticized this system. Of course, we label people when we give them a categorical diagnoses from within this manual. And people may feel that they're sick. So for example, if somebody labels you as having cyclothymic disorder, you may in fact feel that that means that you have a psychological problem when it might not be a problem at all for you or for anybody that lives with you. Second, sometimes people feel that once they have a label, they have an illusion of an explanation. The other problem is that once people do have a label, they may indeed feel stigmatized. So I've often heard parents of children who have a difference like Down syndrome, who are very bright, feel that the rest of the parents in a school, for example, might stigmatize their child. Stigmatize means when you treat someone like they're not as good as, or that they're different from the other people. There have often been critiques of the problems with unreliability. So a label based on an arbitrary set of symptoms may lead to unreliability. It's very hard to have exact numbers or exact definitions that everyone agrees on when you have a checklist observational system like the DSM. So it depends on training and the evaluator's skills. While there may be possible disagreement, if people study the system enough and use it correctly, there's less of a reliability problem. The other important issue is that a specific diagnosis can have several entirely different causes. So a similar source of a problem can be expressed in very different symptoms and behaviors. Sometimes people go through the same psychosocial trauma. One person might end up becoming very anxious after that, having flashbacks, which are memories of the psychologically traumatic event. And other people might become depressed without any kind of flashbacks. So they experience the same trauma, but they react in very different ways. So we have to account for the individual differences. And for each cause, there can be an entirely different treatment. There's no clear relationship between the DSM diagnoses, causes, treatment, and the outcome of treatment. Let's look at sociocultural problems and economic preoccupations. There are many different potential outcomes and treatment approaches that can vary with each individual, their beliefs, their values, their attitudes, their culture, their ethnicity, and their resources. So I'm going to give you an example from my home country. If I were treating an Aboriginal woman who was depressed, because of her ethnicity, I would take into consideration her environment, how she naturally would handle that kind of a problem. I might, for example, actually smoke a pipe with her of tobacco, which allows people who are Indian in origin to get in touch with their inner spirit and their dreams. We might focus a lot more on her dreams and her contact with her spiritual ancestors. On the other hand, if I were treating someone who was, say, an accountant in my culture and who had a very white Anglo-Saxon background, I might use a very different type of therapy. I might use cognitive behavioral therapy that was very structured and talk-oriented. In a world of managed mental health care, just to explain, I think this is partially happening in France, but not as much as it is in the United States. In the United States, managed mental health care means that people pay for private health insurance. And if they have private health insurance, the company who runs the private health insurance may decide what kind of treatment they can have. This in some ways has been very difficult for psychotherapists, who may be told they can only see their client for a short number of sessions, let's say 6 sessions, for brief therapy, and they may be expected to give drugs even when that's not the best thing for that particular individual. So somebody who is, for example, a psychoanalytic psychotherapist who would like to give long-term treatment to their client might not, in fact, be able to do so. So the pharmaceutical companies, unfortunately, also own the managed care health insurance companies. So they may, in fact, promote a biological or genetic vision to sell their products as an alternative to psychotherapy. So there's a problem of patient rights and risks associated with using health insurance. And it's the role of professionals involved in authorizing the process for payment from a managed care company. I once worked with battered women, and I found that I could not put depression down, even if I thought they were depressed because of what was happening in their lives. I didn't put that down as a clinical syndrome, because they might be prescribed medication and that's all. I had to come up with another diagnosis, and one for which they might get psychotherapy. In that case, I've used adjustment disorders, which was also a true diagnosis. I also had to consider whether their case would go to court and their children could be taken away from them if they were seen to be having a disorder of some sort. So there's all sorts of things to consider when you're giving a DSM diagnosis, in particular socio-cultural contexts. Let's come to some conclusions for today about the DSM, its advantages and disadvantages. This polythetic form of the DSM, and of course that means that there's many different axes, generates diagnostic heterogeneity. In other words, many different people with different symptoms will have the same label. They'll fit in the same category. Another problem, or a problem with this approach is, although it's helpful, it does not contain an explanation of the relationship between Axis 2 personality disorders and Axis 1, which are the clinical syndromes and non-personality disorders. We also don't know the way in which chronic childhood and developmental problems interact with personality disorders. There's some issues that have been long neglected in the DSM, but they're likely going to be addressed in future editions. And there's often ongoing current research in some of these areas too. One is, how do disorders unfold over time, or the development of disorders over time? Could someone who has slightly odd behavior in adolescence, who doesn't fit into school well, later develop a personality disorder as an adult? That would be an example that's not well specified yet. And we also are finding more about the genetic and biological underpinnings of personality disorders. We don't know enough about the development of personality psychopathology during childhood and its emergence in adolescence. This is something that is starting to develop, and we will see more of in the future as well. We also are making connections between physical health and physical disease and personality disorders. So in fact, somebody that has a low functioning thyroid may have a slightly depressive personality. That could be an example of a connection that's already been made, and more will be made in the future. We also don't know a lot about, is one treatment better than another? This is possibly because the tools to measure what better means are not completely refined. It's not necessarily easy to follow people who say they're feeling better after depression and know that indeed they won't have symptoms that recur. So it's hard for us to talk about the effectiveness of various treatments, talk therapies as well as psychopharmacology. And I'm going to end on that note. Are there any questions?